Welcome back to the Psychiatry Boot Camp podcast. I'm Dr. Mark Mullen. Today we're talking about capacity assessments. This can seem like a really bread and butter topic for psychiatry residents, and in truth it is. But as you're learning about capacity assessments, I would just encourage you to keep in the front of your mind that while it seems like a straightforward task for us at times, the content that we're dealing with is grave. We're talking about ensuring that people have autonomy over their own bodies, or at least as much bodily autonomy as we are allowed in the United States in 2023. And while sometimes a capacity assessment is really straightforward, usually the reason we as psychiatry are consulted in the first place is because it's not straightforward. So we really need to know how to do this forward and backwards so that when things come at us sideways, we can keep our footing. To put a fine point on it, if you got into medicine to care for the least among us, people who are having the most difficult and scary times of their lives, and to stand up for the rights of vulnerable people who are not in a place to stand up for themselves, then capacity assessments are for you. Today's guest is a repeat, but this is the first episode that I ever recorded, so you get to hear his intro twice. Welcome to Dr. Rajesh Tampi, Editor-in-Chief of the World Journal of Psychiatry. He's also the Chairman of Psychiatry here at Creighton University School of Medicine, and is an adjunct professor at Yale School of Medicine. He's a past president of the American Association for Geriatric-Psychiatry, and a distinguished fellow of the American Psychiatric Association. Welcome, Dr. Tampi.
Thank you for having me, Mark.
I think we'll probably go from the consult liaison lens for this question because that's where you see it most often. And I think it's important to note that in the hospital, this is a frequent consult, and it's actually a consult that I think sometimes psychiatry residents complain about, maybe throw a little shade. And the reason why is because any physician has the ability to determine capacity. It does not need to be a psychiatrist. But Dr. Tampi, my question for you is, why are we as psychiatrists uniquely positioned to be consulted on this question, even if theoretically any physician can do it?
Right. And I think this is the way the specialties have been set up, because we do a lot of talking to the patient and not just looking at the medical records in the lab. So I think psychiatrists have come to be uniquely set up because we spend more time with the patients. We don't do a curbside, or we don't do a quick dashing through the door seeing the patient. For us, we spend time, we get to learn more about the patient. So that is why we are being asked to do. So it's not any physician, Mark. Any clinician can do the capacity evaluation. And any clinician must be able to do a capacity evaluation, because remember, fundamentally, we all have a fiduciary relationship towards our patients. We have to be advocates for our patients. So yes, we are the ones who are uniquely placed, but any person who is treating a life should be able to do a capacity evaluation so that they can fundamentally advocate for the best for that person.
Love that. So let's say there's a really complex case and we put our heads together and we're still having difficulty kind of making sense of things. Is there anybody else in the hospital that we might want to involve in the care of this patient?
Absolutely. I mean, if there are family members who can tell you the history of the patient, if there are loved ones or other people who are there, that might be very, very helpful. Remember, you can always have an ethics consult if you're in doubt. And always talk to your hospital attorneys. And, if there are things that you're not sure what's going to happen, they're your colleagues. This whole is a multidisciplinary team, whether to discharge a patient whose capacity is not, certain, and that, we're on the fence with that. You don't want to take a chance. You don't want to put the whole system in a jeopardy just because you couldn't spend 5 minutes talking to a hospital attorney. For me, these are my colleagues. Ego aside, there is nothing wrong with asking a colleague, hey, I'm not sure what to do in this situation. What would you recommend based on your previous experience? And I have had times and times where, I'm not sure. I've asked a hospital attorney, and they're like, Dr. Tempe, let me just make this call for you, and then that eases the burden and, another set of eyes helping you with that particular situation.
Awesome. And I think in addition to the legal aspects of these cases, some of them are really complex medical decisions that it really takes a specialist to kind of know all of the risks and benefits of. So depending on the circumstances, you may even take a member of the team requesting the consult and bring them in to kind of help you navigate the conversation around the medical decision making.
Oh, absolutely. And remember, many a times patients are assenting and not consenting in informed consent, because what do you know about doing a cardiothoracic surgery? What can you tell about the prognosis of a valve replacement? I don't pretend to do that. I say, well, generally this is what happens. So having a person who is asking you to do the consult be there with you while you're doing the explanation part is always helpful. And it's again treating each other with respect. I am very respectful to all my colleagues. I treat as with our residents, any person who is there, even a medical student, I tell them how I arrived at the diagnosis and the assessment plan, so that everybody is crystal clear that what we are doing is together, and autonomy trumps everything else unless it's an emergency situation. People may disagree with you on that, but that's a disagreement. But when you consult, remember, you're a consultant. You give an opinion, and the primary team then makes a decision on that opinion you have furnished. And remember, all consults are seen by every member of the other team. So you have to tell the patient that, hey, when you do the consultation, this is not like our chart where we can close it and nobody else can see it. Everybody on the team can see it. So another important point is, before you do the consult, you have to ask the person who's making the consultation, hey, have you told the patient that a psychiatrist is going to come by and talk to them? Because you don't want to get there and say, they're like, oh, the patient is like, are you my orthopedic surgeon? Sorry, I'm the psychiatrist. And they're like, why do I need a psychiatric consult? It has happened time and again. So what I tell the residents is, before the consult is there, make sure that you have a consult order, you have a reason for consultation, and it is documented somewhere, not just asking the ward clerk to call you and say, hey, come and see John in room 11. Well, that's not good enough for me.
Let's do a little example just to help our listeners kind of flesh this out and see what it takes to get a really good consult question. So here's just kind of an example for you, Dr. Tampi. This is a consult coming from the orthopedic surgeon, and you get a page and it says, patient in room 101. Does he have capacity? How would you respond to that page?
Yeah, so, if you get paged, I just call the number and then say, and I always address myself and Dr. So-and-so, because remember, that's how you want to be addressed. Yes, you can be on first name basis when you see face to face, but before that, Dr. So-and-so, I just heard this call, may I know who was calling me? So if it's the resident, if the person comes and says, I'm so-and-so, I'm like, I always tell the resident, please introduce yourself, because I don't know you're the attending, the chairman of the department, or the ward clerk, right? So unless you introduce yourself, I don't know. So introduce yourself and tell me what question you're asking. I'm always very polite, and I redirect and teach. And I would say, okay, so what you're asking me is, does this patient have capacity, and capacity for what? And then if the person says, oh, we want capacity for whether the patient can take medication, I said, that's a good point. So let me help you do that. And if they are there, I'm like, hey, are you by the bedside? Let me come and talk to the patient. Let's do a quick chart review, and let me see if I can help you. If they say, well, I'm busy, I'm like, all right, you know what I'll do? I'll see the patient and I'll call you, and then I will discuss the treatment plan with you. Does that sound like a plan to you? And I always say, have you put the consult request in the chart, and has it been approved by the attending? Because the only person who can approve that is the licensed independent practitioner who's taking care of the patient, not a resident. The resident can put the order, but it has to be approved by an attending. Because if you ever go on a consult and the patient says, I was not told, it could constitute an assault. Because remember, it is not a record that is private. It's a record that can be seen by other members of the team.
I think that's exactly the kind of hard-won wisdom that our listeners are going to really appreciate. That's not something that was on my radar as a PGY1, but it's something really serious.
Always ask if the consult order at Cleveland Clinic, we used to make sure that the consult order is done and it is noted in the chart so it can be tracked. Because for us, we also needed to know how many consults, what kind of consults, and capacity evaluations were one of the reasons why the consult would be called. And our take was, any provider can do a capacity assessment. Call us in doubt.
So when this orthopedic surgeon asks you, does this patient have capacity, you are respectfully getting to a more specific consult question, making sure the consult has been ordered, the patient has been informed. And, one important teaching point, capacity is a medical decision. Competency is a legal decision. So we need to make sure we have our terms straight. But I kind of want to go down this rabbit hole real fast, because sometimes you really do have a patient who is kind of globally incapacitated, and really does seem like that they do not have the cognitive ability to make any of their own medical decisions. So how would you deal with that type of a patient?
Right. So remember, we do capacity assessments, right? Whether the patient has capacity. And remember, capacity assessments are situation specific and time limited. So I cannot tell whether the patient will have a capacity 4 days from now. They might be in a motor vehicle accident. You don't know. So as of when I write my consultation note, I always put as at this time the patient has the decisional capacity to make this decision. That's it. To take medication, discharge against medical advice, refuse surgery or accept surgery. Global capacity assessments are never done because it doesn't happen that way. So you answered a specific question, which is situation specific and time limited.
So is there any way then to make sure that a patient gets the care they need if they never do come around to having capacity? If it's an anoxic brain injury that does not have a high likelihood of healing, if it is, in your case as a geriatric psychiatrist, maybe a major neurocognitive disorder that is not likely to improve, what would be the road that we would go down to make sure that we were getting that patient the care they need and respecting their autonomy?
Well, that's the hospital policy, right? So in any licensed independent practitioner can do a capacity evaluation, right? Uh, and these patients are not your patients. These patients are on the primary medical team. If the primary medical team decides to discharge the patient against medical advice, that is their decision. So the medical legal liability rests with them. Your goal is not to hold the patient down if they don't have capacity. Your goal is to make an assessment and see if the patient has capacity to make XYZ decision at this period of time. And then they need to decide of whether they're going to keep the patient, whether they're going to discharge patients. So there are times where the primary care physician or the primary team feels that, well, the patient may not have capacity, but we don't have space to admit this patient. We don't want to wait. We're going to discharge the patient. It's up to the primary care team. You can try to dissuade them, but each team has to make their own decision.
Gotcha. So back to our example here, the surgeon has now clarified the question for you. The patient just underwent an open reduction and internal fixation of the femur, and the patient is wanting to leave AMA. So how would you phrase this as a consult question?
So you would ask the surgeon to say, so you're asking me whether the patient has the ability to make an informed decision about leaving the hospital AMA now. You've not seen the patient. So can you write it as that? That would be a consult question. So you go, and remember, no tool, and I'm sure that we're going to discuss this, no tool is foolproof. Clinical assessment is what is required. All other tools like the cognitive assessments, the functional assessments, only add to the data that you got from the clinical assessment, which either supports or disproves the information that you have got. So a patient who has delirium, for example, the person is chatty, very pleasant, but has no clue what just happened, and is saying, well, I want to leave because I can go home. And you're like, how are you going to take care of your wound? Is not able to give a good explanation of what they're going to do. That is an important point to remember when you do the cognitive scales and the patient is a 15 out of 30 on the cognitive assessment. Does the patient have capacity to make the decision? Unless the patient is in a good part, of the delirium where the patient is doing really well. Even then, when you do the separation between today and yesterday, or you see the patient today and the patient is like doing so poorly, and then tomorrow the patient is doing better, that gives you more credence to the fact that the patient is delirious rather than having a dementia, because the scores don't improve. So longitudinal assessment is needed. If you see the patient that the person has seen, the patient is really doing well, the cognitive assessment is good, discussing with the patient's family is like, hey, you know what, we can manage him at home with wound care services and all of that, then autonomy trumps. Then you say, okay, well, there is a safe discharge plan. But if the patient has nobody, there's no other plan, he's very delirious, his cognitive scores are going all up and down, then you say that the patient does not have capacity to make decision, and the primary team then takes the responsibility of keeping the patient in the hospital till he's medically cleared to go.
And such a great example about how capacity is not always so black and white. There are societal factors that go into whether or not a patient has the capacity to make a decision. So that's a great example of, if this patient has the social support to do the wound care at home, then they may have the capacity. But somebody else who is in a similar mental state may not have that capacity. It's so contextual. So we're looking at the whole picture when making these assessments.
Getting a longitudinal history, getting collateral information is very important. And what I always say is when people are at a rush, I'm not going to rush to discharge the patient because I have to do my assessment before I can say if the patient has the capacity to make decision to either do this or do that, right? So you have that choice. And I convey that to the team. They may not like it, but your role, remember I said it in the very beginning, you have a fiduciary role to protect your patient. Second rule, err on the side of caution. Nobody should be able to force you to do anything unless you want to do that. So, don't let anybody force you to discharge the patient unless you think that the patient can go home with a safe discharge plan. Residents get frightened when an orthopedic surgeon comes and thumbs on the desk and says, discharge the patient. No, it's your patient. You may decide to discharge, but I'm recommending that the patient needs further evaluation. Well, if there is a disagreement, you always have your attending, right? As a resident, you always have your attending. It is then goes attending to attending. There are times which have happened many times in the past where, as I was the chairman of Cleveland Clinic Akron General, I would get a call from the ED, from the attending who disagrees with the attending on call. But as the chairman, they call me. I'm like, absolutely not. I hear the case and I say, err on the side of caution. I do not care if the hospital has to take a little bit of a hit on their length of stay. Safety comes first. See, that's where talking to the attorney, having your attorneys who know you becomes so important. I'm like, hey, I have the situation. There is an irate attending calling. My attending on call has discussed this patient, does not feel safe. They're like, doc, don't worry about it. We'll talk to the attending. We'll talk to that. And you know what? As chair to chair, I call the chair of the ED and say, can't discharge. Sorry. We'll have to find a way. But you always do it in a professional way, not as if antagonistic, where like you said, he said. No, this is a clinical disagreement. This is not a personal disagreement. And it happens all the time. That's what makes us all good at what we do, because we learn from these experiences. So at never a time you would raise your voice or be disrespectful. I'm like, no, I beg to differ, but I think this is a situation. I'm good. Let me call the president of the hospital and the attorney, and we're going to figure this out, and I'll come up with a plan. And invariably, it's happened so many times. The plan is stop the conveyor belt. Let's assess, get some more information. We'll decide in the morning or anytime, and then we'll all come together as a team. That's where the multidisciplinary assessment comes.
And to our learners, some of these high level conversations might sound like enough to make your head spin, but the point really is that as clinicians, we always rely on our own clinical judgment. And as a resident, you're practicing under your attending's license, so you have their clinical judgment as well. And, it's definitely true that the more challenging the case, the more you're going to learn from it and the more it is going to stick in your brain.
Correct. And the important thing about that, Mark, is that you remember you and the attending are a team. You are not seen separate from the attending. So if you are being pressured in any way, and I say this because at times people are pressured to do things that they don't want to do, don't do it. Stop the chain. Say you feel unsafe. As a resident, you have the right to say, you pull the chain and say, it stops here. It goes to the attending. From the attending, it goes to the division chief. From the division chief, it goes to the chairman of the department. And many times I have gotten involved because it's lack of knowledge on the other people's part. My goal is to teach them as safety first. And always, safety comes first. And we have a fiduciary relationship towards the patient. And if I have to stop the chain, and I will pull that plug and back the resident to doing that. So never be flippant about this. Never think, oh, I'm going to inconvenience anybody, because thinking that you might actually save a life by pulling the chain and saying that I'm going to stop the train here and make sure that everything is done safely.
And that's really how we promote a good work culture, isn't it? We're all a team. No one's worrying alone. We're all here to learn. So let's talk about what capacity is before we talk about how to evaluate capacity. So, some things to keep in mind with capacity. First of all, an individual has capacity until proven otherwise. Another thing to keep in mind, capacity is task specific, situation specific, and time limited. Where do we see that, Dr. Tampi, that capacity is task specific? Could you give us an example of that?
Yes, for example, a patient who has the capacity to make decisions about, taking a medication may not have capacity to be able to decide whether they can do a complex neurosurgical. They will accept a complex neuropsychological psychiatric procedure, which needs higher levels of cognitive functioning. So a person may say, okay, I'll take the medicine versus I'm going to consent to a neurosurgical procedure that has a mortality rate of 30%. That's a different level of capacity.
And that's really why it's so important to have a concise consult question. What is the question? What is the period of time? We're including that in our documentation. Dr. Tampa, we also say that capacity is functional. What does that mean, that capacity is functional?
Well, so functional means it's just task specific orientation, you know? So in the sense that how is this person able to use their cognition to do a thing, like take their medication, accept treatment, accept surgical procedures, decide to go home. So that's why it's a history with a cognitive assessment and a functional assessment. So they're all linked together. So they're not a separation.
So just because someone has a diagnosis of schizophrenia per se, that does not mean that they do not have capacity across all domains.
Absolutely, absolutely. So no illness precludes absence of capacity. So just because you have dementia doesn't mean that you don't have capacity to make a decision. So a mildly demented patient may have capacity to say, doctor, I will accept the Aricept that you're prescribing for me, but they may not have capacity to be able to sign off their will or any of those kind of things. So no particular illness is that. Even schizophrenic patients, and remember, schizophrenia is multiple different illnesses with different prognosis lumped into one category. Even a schizophrenic patient may have the ability to make a decision to accept treatment and to go to a nursing home, whereas they may not have capacity to be able to, approve more complex tasks. So again, no one particular illness precludes you from lacking capacity.
And while it's true that a patient may have the capacity to make one decision and not the other, we can get into really dicey territory really quickly. And here's the reason why. Because disagreement or refusal with medical recommendations does not equate to incapacity, nor does acquiescing to the treatment prove capacity.
Correct. That is absolutely correct because, you know, capacity, there are different levels of capacity for different tasks. So the more complex interactions, you need to have more cognition to be able to do that, you know. Whereas simple things, people can assent saying that, doc, I'll take them. And I mean, that's what happens in 90% of our patients. They know you, they trust you. They say, doc, if you say this medication is good, I'll take you. Is it really informed consent? Absolutely not. It is probably informed assent, where they're assenting to the treatment.
I think at this point about how just because a patient agrees with us does not necessarily mean that they have capacity. And on the flip side, if a patient disagrees with us, that does not mean that they don't have capacity. This is a really important point because this is where bias comes into play. And we always need to be on the lookout for our own biases. So again, we're really defending our patient's values, not simply practicing the medicine that we would want should it be ourselves.
Correct, correct. And if you remember, when we see our patients in the clinic, you remember we tell the patient that you are front and center to the treatment plan. Unless in an emergency, you make the final decision of whether you want to take the treatment or not. We will continue to work with you and we will continue to educate you. That gives you a better sense of, making a value added judgment. That gives you the ability to make informed consent and accept the treatment. If you don't, we will still continue treating you. But if it is an emergency, the patient is frankly suicidal, getting admitted to a hospital, they really don't have the capacity because of their severe depression or anxiety or whatnot. They're not making a judgment which is clouded by their mental state. So it is important to remember that you have to work longitudinally with the patient. A spot diagnosis is, I think, the worst thing you can do in terms of capacity. It's like black or white. And like you pointed out in the beginning, it is not black or white. There are many gray areas and you need more information because you can come to a definitive conclusion of what needs to be done.
So when we're talking to the patient about capacity, we're really specifically trying to understand, is the patient able to consent to a particular treatment? And informed consent is based on a few different tenets. The first would be availability of relevant information. The second is our topic for the podcast today, capacity to make a decision, decisional capacity. And then the third one is really interesting to me, and it's the ability to make a free choice, also called voluntarism. Could you explain this concept to us?
Absolutely. So voluntarism is without any coercion from anyone, including loved ones and family members, where the patient is making a free choice to accept or decline a treatment. Unfortunately, this is way more true of people with SPMI or the older people with dementia. Family members are usually present and they coerce the patient into taking treatment. What I always caution at that time is I try to meet with the patient alone and say, do you understand why we're prescribing this treatment? And don't take it because your daughter or son or wife wants to take it. We want you to understand why this is important. And the reason is X, Y, and Z. Now, will you give me the permission to prescribe this medication or this treatment? And if the patient says yes, I'll say, let's continue talking about it. Every visit we will go revisit this, whether this is a good treatment for you. If the patient says no, I will still continue to treating the patient. Treating the patient is not prescribing the medication. Treating the patient is treating the whole person, having them come back to the appointment, making sure that they're safe, they're taking their medical medication, they're going to rehab. This is all part of the treatment, and I happen to be one part of it.
So that is such a pragmatic answer to voluntarism because it can get really confusing, really difficult when voluntarism is the question. Is the patient making a free choice? Is there some undue influence at play? And what you're saying is, let's be pragmatic about it. If we have questions about voluntarism, let's get everybody around a table. Let's provide as much education as we possibly can. Let's try to come to a clear decision that is in the best interest of the patient and also respecting the patient's autonomy.
Bottom line, Mark, medicine is a field where there is a lot of gray areas and only longitudinal information and people sitting down together in multidisciplinary teams to discuss where you will get an answer. Even in those situations, you sometimes get it wrong, and accept that that is part and parcel of medicine, and you learn from experiences. And you don't blame each other. You don't blame the patient. You continue to strive to do what is best for the patient based on available information.
I hope that all of our rising PGY1s listening are hearing my department chair tell you that even he makes mistakes. So it happens to all of us.
These are scars of life. If I never made mistake, I wouldn't be here. To err is human, right? Forgive is divine. So from your department chair, you can hear that if you tell me you've never made a mistake as a human being, I would say you're lying. And the thing is, that is acceptance of what life is all about. And that's what psychiatrists should do. And Mark, you probably heard this when we say it. Psychiatrist is not a prescriber or a provider. Psychiatrist is a healer. A person, who listens intently, carefully to understanding other people's problems, pain, suffering, misery. We try to help with medications, therapy, but all treatments are included in that part. And we are part of the wheel, not the wheel itself. So learn from each other's mistakes, learn from each other's successes, be patient, learn to work with what you have, learn to get more information, and leave the ego outside the door. Because like I heard one of the coaches say, when they asked him whether you mind coaching the women's team, he said I coach people, not gender. Exactly the same. I treat people. I don't treat statistics. I treat people. This is the human element that is so important that we forget. So that's what makes it such a great profession, is that you get a little bit of sociology, you get a lot of psychology, you get a lot of medicine, you get a lot of ethics, you get a lot of politics. Well, you learn to work with it. And psychiatrists are well served to be able to do that, because that's part of our culture, as being a psychiatrist.
Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner, because this is the question bank that I used to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word Boot Camp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, Boot Camp. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Okay, so now I am putting myself into the shoes of our listener, about to walk into a patient room to do a capacity assessment. And the question that I'm thinking about is, does this patient have the ability to understand and the ability to appreciate the information before them to make an informed and free choice? So let's sort of go into the 4 different processes that we'd want to look at when assessing decisional capacity. The first process would be, does the patient have the ability to understand relevant information? So what does this mean?
Understanding factual information. Why are you here in the hospital? What surgical procedure have you had? What medical procedure have you had? What did the doctors talk about the prognosis? In general, what the patient has a general understanding of that. If the patient says that they're in the hospital for a skin problem, but they really came in for, a cardiothoracic surgery, that's a problem. So factual information. Sometimes older patients who are also having some dementia may have been explained why they're there, but they forget. So again, getting collateral information is so important, and getting longitudinal history from the caregivers or loved ones, family members, and the nurses and doctors taking care of them is equally important.
After we're able to determine whether or not they understand the factual information, then we need to determine, do they have the ability to process the available information? So what does this look like? How can I determine whether or not a patient can process the information?
So understanding, appreciating means using the factual information and contextualizing itself to what will happen to you. Okay, sir, you are in the hospital. You've had, from what I can see, you've had heart surgery now. It's just been 2 days. The doctors tell me that, you're getting upset and agitated, not sleeping well. You're confused about what's happening, hearing things. Now, how does, your going home help? Because that's what I heard. You want to go home. The patient is like, well, I can take care of myself. I can take care of the medication. And he's completely, with a lot of tubes and a catheter and all of that. And he's saying that. So you can say, well, as you can clearly see, you have all these tubes that they're giving medications and they're making sure your urine is running. Oh, I can just pull that out and go home and take care of it. So he's not able to contextualize the information that he just had cardiac surgery that needs further stay for improving his prognosis.
So we determine if they can understand it, and then we determine if they can appreciate it. And by that, we mean both process the information, but also personalize it in their context. And finally, to state a clear preference, and a preference that over time, one thing you can do to determine whether or not a patient has the ability to appreciate information is, does the preference stay consistent over time? And if the preference does change over time, why? Is it a rational reason? Is it an irrational reason? Is it a result of some treatable medical or mental health condition that we can take care of before making such a major decision? Again, every situation is different.
Absolutely. So, understanding, appreciating, making a choice. And choice is a rational choice. A person who says that, hey, I have all these things happen to me. I had massive surgery, and I was in coma for 3 days, and now I can just get up and walk home, and feel that is not making a rational choice. And then stating the reasons for the choice, for the rational choice. Hey, if I go home, I'm going to fall, I'm going to have an infection, I may have a seizure. All of those are rational choices. If the patient says no, the patient should have a good understanding, should contextualize it, make a rational choice, and be able to state the choice, or at least make the actions to what they want to do. Trying to pull out the tubes and try to walk out while saying, I'm going to stay, is not stating the reason for the choice. They're already showing you that that's not what they mean.
Dr. Tampi, you mentioned this briefly earlier, but when you're doing a capacity assessment, are there any standardized instruments that you can reach for when assessing decisional capacity?
So, Mark, like I pointed out, no standardized scale. The Hopemont and the MacArthur's and McNaughton's is the one, right? And those are ones, they're all copyrighted. They're all very long, take about 45 minutes, and they're not always prove the same point. So a good clinical diagnosis is the most important thing, and all other instruments are only tools to confirm or reject what you have found in your clinical assessment. So clinical assessment is the key, and capacity evaluations are clinical decisions, clinical interviews and assessments that are made.
And listener, just so you know, it's not that this has not been studied. This has been studied. It would be nice if it was a cut or dry thing that we could just give a scale and make a decision on capacity, but we can't. So things like the mini mental status exam, the St. Louis University mental status exam are extraordinarily helpful tools, but using cutoff scores has not been proven to be helpful in the research. So we always need to do a thorough clinical assessment.
So each of these tools may, test understanding and appreciating, but not the ability to make the decision. So again, you have to have all of those line up, and only a clinical assessment will show that for you.
So let's get into documentation, because this can be a medical legal question at times. And as a resident, that's really what you're doing is you're going in to do the assessment, writing the note, and are you able to defend your reasoning, give pertinent facts, the process that you're going through to evaluate it. So, Dr. Tampi, after you've done an assessment, could you talk a little bit about how you would go about writing the assessment and recommendations?
So that in different places have different ways of doing it. At Cleveland Clinic, we had a dot phrase, which showed understanding, appreciating, making a choice, and stating the reason for the choice as the four things. And it was a dot phrase, because you don't need to write a whole note for just a person who has the capacity to make a decision or not. But if you're getting a consult for a psychiatric assessment and capacity is part of that assessment, then you can write the long note, which you normally do. And you do a good history, you get collateral information, you do a good mental status examination, you do the cognitive assessments, and you do the confusion assessment scale, all of those, and then you summarize the case, differential diagnosis, and capacity becomes part of the assessment and the treatment plan. But if in a jam, you are busy, they just ask you for whether the person, they're not asking for anything else. You can do the understanding, appreciating, making a choice, and stating the reason for the choice. The important thing is for the service to decide which way they want to go. And we decided that, hey, we need to have the dot phrase, because there are a lot of people who never needed psychiatric assessment, but capacity was one of the questions. Anybody could use it. And the legal team and me and the consult service folks introduced it to everybody. We had training for all the license providers, and anybody could use that tool. And, it took us 3 years to do it, but we repeatedly did the same. And now everybody, any license provider was expected to do the capacity evaluation and call us if they're not sure what to do.
That's a really great systems level approach to a problem like this. And to our listeners, as a resident, this is one area where you can really impact patient care and even change the entire culture of a healthcare system, because we're the ones writing a lot of notes, using a lot of the electronic health records. So make your own dot phrase about capacity assessment. I promise you, as a psychiatry resident, you will be doing this all the time. So go in, make your formula. Does the patient have the ability to understand, appreciate, make a choice, communicate the choice? Make your dot phrase, use it, and I'm willing to wager that it will really catch on like wildfire and really be a way to impress your attendings.
And run it by legal, and this is the team can do that. The consult psychiatry team can do that. Run it by legal. Make sure everybody's okay with it. Everybody knows what the dot phrase is, so any service can use it. And then the number of unnecessary evaluations that come your way will diminish, because people are empowered with the ability to do this assessment. I mean, they think it is something special or technical that psychiatry does. It really is not. Any licensed independent practitioner should be able to do it. We have unfortunately been handed the baton, basically because we spend more time with the patients. But for any medical student, you have a fiduciary relationship towards the patient, so you should be able to do a capacity evaluation, because you're advocating for the patient, and the patient has capacity unless proven otherwise.
I think the other important piece on documentation here, the consult services that I've been on, which are several, typically do the full psychiatric evaluation and include statements about capacity in our assessment and plan. And when you're writing your assessment and plan, all about your clinical reasoning. So you're not simply stating facts, you're not simply listing information that can be found elsewhere. In the note, you are talking about how you're weighing all of these various factors: family involvement, voluntarism, the patient's cognitive ability, the medical facts surrounding the case. And you're talking about, I am weighing all of these factors this way, and in the first person, this is my medical recommendation.
Correct. The other thing to remember, Mark, is, if you're doing a lot of documentation for just a capacity evaluation when they didn't ask you about treatment, that's a waste of your time. And, when you look at justice, the ethical principles of autonomy, beneficence, non-maleficence, and justice, if you have only one psychiatrist on and you have 40 patients to see, and I'm making that person do notes on all 40 patients, that's not justice. That's a waste of scarce resource like a psychiatrist doing that. So remember, we all have a responsibility to make sure that our healthcare doesn't lose money, or our colleagues. You asked about burnout, right? Our colleagues don't get burnout. So anything that can streamline the process, have a multidisciplinary input into that, and you only do what is asked about. You're doing what you're talking about capacity. It is situation specific and time limited. You are asking me whether the patient has capacity today. I'm giving you that statement. You are not asking about whether this patient should take an antidepressant or, go for therapy. Why would I be commenting on that when that was not the consult question?
Dr. Malin, our consult attending here at Creighton, always reminds us to work efficiently. Do a really good job, be thorough, but be efficient. What is the question? And give the answer to a question in a way that the primary team can really understand, and for the sake of our conversation today, also appreciate. So let's do a hypothetical case. I kind of wrote one up that I think is really difficult, and one that is something that a lot of psychiatry residents are probably thinking about. I think it's a little bit of a fear-inducing topic, so let's get right into it. This is a 48-year-old male who's admitted to the hospital in respiratory distress. He's got a 30-pack-year smoking history. He's found to be COVID positive. He is not vaccinated. He's put on high-flow nasal oxygen, and the medical team has recommended treatment with steroids and Paxlovid. The medical team tells you, we think this could save the patient's life, but the patient understands from his independent research that hospitals exist to make money, and that the hospital is using him to administer these medications just to make more money. And the patient says he understands that when they give the steroid, dexamethasone, to COVID patients, the government reimburses them such an amount of money that they are essentially simply using him to make that money. So I think this is a really difficult case because sometimes patients are misinformed about medical facts, and it can make the capacity assessment really, really difficult. So what additional information would you want to know when you're answering the consult question of, does this patient have the capacity to refuse this life-saving treatment?
So Mark, just hearing the case, one important thing is, so misinformation is rampant because we have the social media, right? So whenever you meet a patient, get time to sit down with them, talk to them, get the information from them, rule out the usual suspects: depression, anxiety, psychosis, substance use disorders, neurocognitive disorders. After you do all of that, if the patient doesn't have any of these things and the patient has a belief system, there are many religious beliefs that don't have any evidence that they're helpful. You can't medicate or take all of that away. You can try to educate, bring the primary treatment in, and they can provide all the information. If the patient does not have any mental illness that could remove the capacity to make a decision, then it's the patient's choice. It is unfortunate, but it is the choice that people are going to make. And autonomy trumps everything else unless the patient is gravely disabled or at imminent danger to self or others. For example, we all know that we should be wearing seatbelts and driving. Even a 20-mile-hour trip can turn into a fatal accident if you don't wear your seatbelt. But a lot of people still drive without seatbelts despite the evidence, right? Despite the evidence that it can kill. What can you do about that? So what I would recommend in these kind of situations, you should not force your issue. You should try to educate to the point that, you can, and then Well, the patient refuses to take the treatment that is being recommended.
So building that therapeutic alliance, and in this case, using it to try to improve the patient's chances of surviving.
And using your multidisciplinary team to arrive at the conclusion that, hey, this is not because of mental illness. This is a belief system that you cannot change. There are many anti-vaccinators around the world, right? They don't vaccinate. I mean, famous people. What can you do? I mean, could you force vaccinate them? I don't think so.
So let's go through step by step. So remind us again, last time for our listeners, that dot phrase that you used at Cleveland Clinic. What are those pieces? And we're going to go through each one step by step.
So understanding is that the patient has factual understanding of what's going on. Like in this case, hey, he has COVID, and he needs to use the steroids plus the other medications to decrease the mortality from the COVID. Appreciating if he doesn't take it because of his comorbidities, his risk of mortality is X, Y, and Z, or the bad outcomes of this. Then understanding, appreciating, making a choice. So he should make a rational choice based on the information available that either he accepts or rejects the treatment. If it is a personal thing because of religious affiliation, cultural affiliation, any of that, there's nothing you can do about it. Because if the person does not have capacity to make a decision, it has to be due to a cause. This is a choice, not a cause. And making a choice.
Dr. Tampi, how would you respond if I said, I think this is a delusion? This is a fixed false belief that hospitals exist only to make money and are using that patient as a guinea pig to make more money. And so I think this is a result of his underlying mental illness. He has a delusion, and that is affecting his treatment, and therefore he does not have capacity. How would you respond to that? Why is that not the case?
No, so the thing is, if you tell me that, it is a delusional belief, if the longitudinal history says that the patient has had psychiatric problems, has delusional beliefs, has things that have impaired his treatment before, then I would say, Mark, this is just one of those things. Let's explore this further. But if this patient is, everything else is normal, but this is the only belief he has. I mean, a lot, and I say this in the best of ways. A lot of people in the Muslim world feel that if you die, you will go to heaven if you do X, Y, and Z. We don't know any of that. Certain religions may not accept that. Will you force a person to do that because you think that that is the right thing to do? You don't. You offer them the treatment, try to make an explanation, and then eventually you make a judgment that, well, the person is not going to accept treatment. There are many countries where patients are not allowed to take, blood transfusions because they feel that, getting another person's blood is bad for them, right? Those are belief systems. There are patients who believe that. The only time you would treat them is if the person is imminent danger of dying. If the patient is going to die today or tomorrow, only then can you treat. So if this person does not accept the treatment, and the chance of immediate death, is there, that today if they don't take it, they're going to be dead. Well, then the doctors have to talk. The attorney has to get involved. But if not, if this is just a single belief, then there's nothing you can do about it. You just have to accept it, try to educate them, and hope for the best.
So then I guess the next question is one that I personally have had a really difficult time wrapping my mind around, and one that I think I really need to get nailed down if I'm going to pursue a forensic fellowship. So what would you say is the difference between a delusion and an overvalued idea?
Very good. Thank you for asking, because I was just teaching a class earlier and we were talking about this. So you have to differentiate between obsessions, overvalued ideas, and delusions. Obsessions are a person's own thoughts, thoughts, images, or beliefs that come into the person's thought over and over again and cause distress. So they're your own. They're not in the external space. What they say inside your head, it's the thought, oh, I'm bad. That's an obsession. The moral equivalent of obsession is compulsion. You then act on the thought. Then there is the overvalued idea. Overvalued idea is one particular thought or belief that is not abnormal or not in keeping, but is in keeping with the person's social, occupational, religious belief system. So I'll give you an example. I had a lady patient who was a correctional officer. She was assaulted, and they told her, oh, we're going to get you one of these days. and she could not shake that thing out of the head. 10 years later, she was terrified of leaving the house, thinking that those guys are going to come and hit her. But she was functioning normally in every other way. So the difference between an overvalued idea, it is one thought or one idea, which is not all that abnormal. It can happen to anyone, but it is being held with subjective specificity or subjective integrity that you cannot shake that belief. They're not able to do that. But it is not abnormal in based on patients' social, occupational, religious, other functioning. So that is the difference between an overvalued idea and a delusion.
And just to clarify this overvalued idea, so it's a belief that is not necessarily inconsistent with their sort of cultural background, worldview, maybe even a system of beliefs, right? So this patient, he has the belief about dexamethasone. He may also have beliefs about vaccines, other things that we've seen in the last couple of years. So that would be an overvalued idea. And now I'll ask you to contrast that with a delusion.
So delusion is a clearly abnormal thought. So I had a patient who has been treated for a long time for schizophrenia, who still believes that an hearing device has been implanted in his brain and other people can still hear him and they're following him and they're recording everything that he's saying or doing. But he's not able to say why he's the target. He's like, I have no idea why these people are doing that. I have no idea whether, which FBI, which government is doing that. And he still believes that is there, despite all evidence that is presented to him saying that that's not really what is happening. And, the governments in this country, at least, don't implant stuff into your brain without your consent. So that is not in keeping with a social, occupational, cultural situation. And he believes that, but he believes that they're not trying to harm him. That's the importance of what the medications have done for him. He still has that idea, but he comes to treatment regularly. He takes the medication, but he doesn't feel they're going to kill him. Before, he was terrified they're going to kill him, so he was assaulting people and ended up in the state hospital for many years. So now on clozapine, he doesn't believe that they're going to try to harm him, but they're still doing it to him.
I'm sure that all of our listeners are getting very excited about this, thinking about how very soon they are going to be the ones changing lives like this, really helping people to live a meaningful life, live to the fullest of their potential. And I'm here to tell you, listener, it will happen for you. And it really is amazing. Dr. Tampi, just a couple more thoughts from you. Do you have any final thoughts on capacity, maybe for an incoming resident who's a bit nervous about making such a big decision, seeing a patient in the hospital, et cetera?
The one thing I would say that you're not alone. You're in a training program. You have senior residents. You have attendings on your services. You have your program director, and then you have your chairman. We all have your back. So you're not alone in this. Any doubt that you have, you should have the ability to pick up the phone and call any one of us at any time, 24/7. This is a team game, and remember, you're part of the team. You go up and down as you go through your experiences, you become more senior to it, but we all do the same things. So you are not alone. That's the number one thing. Second thing, you are taking care of human life. No amount of effort that you put in to save or help a person is going to go waste. So put in the best effort you can. If you have troubles at home, if you have troubles with other things, leave that there at home. Come with your game face on, because if your mind is clouded, you're going to make mistakes. So give it the best. Remember, this is somebody else's loved one you're taking care of. You need to be at your best to provide them with the best of what you want. Number 4, never hesitate to err on the side of caution. If in doubt, stop, pull the chain, stop everything else, ask for help, and get your attending to weigh in on that, because you are joined together as a team. Number 5, you have to take care of yourself. So work-life balance is good. And like I said earlier, for me, this is a calling, so I enjoy doing this, intellectual exercise and all of those things. But if there are other things that help you, use that. Because when you come on duty and when you're coming to work, you have to be at the best that you can. Eat well, exercise, sleep well, because these are all things that will help you be at your best. Last but not least, enjoy this journey, because if you don't enjoy what you do, it can be miserable. So enjoy this, try to learn the best of it, and try to be the best you can. And it's not what you achieve, but what you overcome is the most important thing. And I'm very proud that you guys are all going into psychiatry. And if I can be of any help in any shape or form, whichever program you're at, I'd be happy to do that because you're a colleague.
Thank you so much, Dr. Tampi. And just so you know, here at Creighton, I really feel everything that you just said. I always feel supported by my professors, my department chair, knowing that I can pull the chain. And I also think to our listeners, that's a really brave thing to do. When you pull the chain, when you're asking for support, when you admit, I don't know something, I'm confused by something, I'm having anxiety about this aspect of my work, you're helping yourself out for sure. You're helping the patient out, definitely, but you're also changing the culture of where you work, and you're helping out all of your colleagues and all of those who will come after you. So be brave, pull the chain when you need to, and be sure you are always asking for support when you need it. Thank you so, so much for coming on our show, Dr. Tampi. I've really enjoyed it.
Thank you for asking me, Mark. Goodbye.
Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.